Hi, class. On to part 3 of chapter 12 Motor Speech Disorders. I hope you're not overwhelmed by all of this information because hang on for the ride. We've got more to go. So, we are talking now about what are the defining characteristics? What are the things that separate each of the different types of motor speech disorders? The first set of motor speech disorders we're going to talk about are the apraxias, and there are a few types of them. So, apraxia, APRAXIA, apraxia of speech being the actual first disorder, but there are a number of apraxias, but apraxia of speech. This is disorder at the level of motor planning and programming. Um, Apraxia is the inability of a person to transform a linguistic representation into the appropriate coordinated movements needed for fine articulation of speech. It is not a language disorder. It is not a disorder of the neuromuscular system. So again, it is a disorder. The person is unable, they have a linguistic representation of what they want to say. It's intact. They know what they want to say. The disorder results in them being unable to now transform that into the appropriate movement so that they can speak what they have planned. Um, it is not because of a language disorder. So this person does not have any trouble with comprehending. They don't have any problem. They don't have any issue with that formulation piece of language. They can formulate their thoughts into what they want to say. Um, it is not the result of a neuromuscular impairment. There is nothing wrong with their ability to move the muscles needed for speech production. Because of that, the the articulatory system is where you're going to see this manifested the most. It usually does not impact the resonatory, the phonatory, or the respiratory systems. It's just impacting the fine motor movements right here in the oral structure for speech. The most obvious characteristics or manifestations, remember that word, what it looks like, the most obvious characteristics are this person will have very effortful, slow speech, lots of pauses between syllables, maybe even pauses between sounds, and they may even prolong some sounds, hold on to them long. They will have distortions of speech sounds. Prosody will be impaired because of that phrasing issue. But there will also be differences in their pitch and duration and loudness. Some issue with what we would normally say stressed and unstressed syllables. They will have difficulty controlling what's stressed and unstressed. Their errors may be consistent in type. So, for example, they're across utterances. So, they may use lots of distortions, or they may use lots of sound omission, or they may use lots of inappropriate pausing. And that may be consistent, um, but the presence of the error will vary from attempt to attempt. So sometimes it will be there, sometimes it will move to a different part of the utterance. Sometimes they'll say an utterance with some level of intelligibility and then make the errors again the next time. So the best way I can give you an example of that is if I'm working with someone and I ask them to repeat the same phrase 3 or 4 times. So I say, okay, I want you to repeat, catch the ball, catch the ball. Say it again, catch the ball, catch the ball. So we do that 3 or 4 times. Their production of each of those utterances, the errors will be inconsistent. They may always have distortions, they may always have inappropriate pausing, but it will sound different each time. Unlike a person, for example, with a lisp, or if someone with a W for R substitution, where every time they say, I see a rabbit, they say, I see a wabbit. That's consistent. the person with apraxia will have inconsistent patterns of errors, even though their error types may be consistent. I know that's confusing. Some other possible manifestations are that they will often have difficulty even initiating the speech event. So, again, they know what they want to say, but they are having difficulty at the level of planning and programming, even turning on the path to motor movement. So, it's time for them to respond, and they can't even initiate the motor movement to respond. So, in problems with initiation of the speech event. They may have groping of the articulators. And what that means is, let's say, for example, the client wants to say the word baby. So they need to get to that bilabial plosive sound at the beginning. They know they need to do that. That's the word they want to say. But they cannot program the movement necessary. So they move without the complete program. So what you may see is, oh, who's that crying in the other room? Now it's time to respond. And they say, that's the baby. Okay, they're groping with the articulators until they can get them to the point of articulation to then proceed with the sound. Another really interesting feature of apraxia is people with apraxia tend to be pretty sensitive to automaticity of responses. And this is back to when we were talking about motor learning and practice, and then learning things as a unit. So, for example, if someone with apraxia hears the person next to them sneeze, they may perfectly respond, bless you, perfect articulation. It is an automatic response that they have learned. They've stored it somewhere in the brain as a motor unit, and they can pull on it and say it in that situation. Now, if that same person were sitting in therapy with me and I said to them, I want you to say, bless you, they may not be able to say it correctly. But in response to someone sneezing, they can say it. It's because in that situation, it's an automatic response. It's a pattern they've always learned. But when you ask them to say it outside of that automaticity, then it becomes an issue. If when we're assessing someone, or if when you're just listening to someone, but if we're assessing a person that has multiple speech errors, but they're using a fast rate of speech and their prosody is normal, so the pausing between phrases, the pitch raises, and the loudness differentiation, that's all typical or average. We are not looking at apraxia. Those are just the biggest hallmarks of this, the very slow rate of speech and impacted prosody. What are the causes or risk factors for apraxia of speech? Well, apraxia of speech is the result of neurological damage. So, as an acquired disorder, which is what we're talking about right now, acquired apraxia of speech, it is the result of neurological damage, and it can be from things like a stroke. Remember stroke? Cerebrovascular accident, stroke. It can be from traumatic brain injury. It can be from infections. So things like meningitis. It can be from neurodegenerative disease, Parkinson's, ALS. The site of lesion, that's a term you'll hear me talk about a lot more when we get to the chapter exclusively on adult disorders. Site of lesion, where in the system is the disorder happening? Site of lesion for apraxia is debated because it can be associated with multiple sites within the brain, but the one you should already be aware of is Broca's area. Broca's area in the left frontal lobe, remember, controls the fine motor movement needed for accurate speech production. So it is very likely and relatively proven that there is almost always some impact in Broca's area that is responsible for apraxia of speech and acquired apraxia of speech. Okay, under the umbrella of the apraxias, the next one is childhood apraxia of speech. And it's a very important distinction because in talking about acquired apraxia of speech, when we were talking with an adult, it is a motor disorder, the disorder of planning and programming, right? But when we're talking about it in childhood, it is a phonetic motoric disorder because now unless this is a child like 10 years old that's already had really good speech and now has some acquired damage to the central nervous system, that's acquired apraxia. But if we're talking about the developing child coming up from infancy to toddlerhood to preschool who is not producing speech correctly, and its severe intelligibility impact. And then you'll see there are some other symptoms that come along with this or other signs that come along with this. It is a phonetic motoric disorder. These children are unable to, I'm going to use the word translate, but I'm going to come back to it in a minute. These children are unable to translate linguistic, phonetic information that they're receiving concerning speech production into accurate motor behaviors. They cannot learn, or they have a very difficult time learning the motor behaviors that they need to execute the speech that they're planning. Okay, I said I'd come back to that word translate. I just want to make sure that you understand I'm not using that word in the sense of, first of all, hearing. This, we've ruled out hearing. Hearing is not the problem. And we're not talking about a language disorder. So it's not translate in terms of I heard this, but I didn't understand it. Okay, this child is hearing, they're understanding, but they cannot then translate what they're understanding into the signals to give the muscles to produce their targeted planned speech. That's where the translation breaks down from what my formulation is to now how I tell those muscles to move and produce this. Phonetic motoric disorder. The reason we're going to call it phonetic is because of the additional problems with that. Remember, this is now the developing child. This probably came along from the time of birth. This was not an incident that happened at the time of birth. This is just part of this child's developing neurology. So the additional issues here are going to be considerable delays in the development of speech production because they didn't ever have that neurological system that was designed for that. So they're going to have considerable delays in the development of speech production. When they do begin speaking, they're going to have a very limited sound inventory. In fact, in my experience, many of them have almost exclusively vowels as they start talking. The consonants are much harder. And it's, again, not because of execution, not because of muscle issues. It's that planning and programming. And they have severe intelligibility issues. They're very difficult to understand. And then the really unfortunate piece is they make very slow progress in therapy. Some of these kids even end up using alternative means of communication, something we'll talk about in one of our very last chapters of the semester. They need to use communication devices. Not all of them, not even the majority of them, but some that are most significantly impacted. So what are the causes and risk factors for childhood apraxia of speech? And by the way, I can tell you that it is very rare. Rare enough that in my 30 now years as a speech pathologist, I have really only seen probably 3 kids that truly have significant childhood apraxia of speech. I've probably seen a few more that have a very mild form of it that really is more like treating a regular speech disorder. But as far as super severity, I've probably only seen 3 or 4 kids. So the causes and risk factors. There's probably a hereditary component. Again, that's something you're going to hear me say many times this semester about many of the various disorders. But we know, looking back in family histories, that we do hear, yes, I had an uncle, or yes, there was a cousin. I had two brothers on my caseload a number of years ago. It comes along with some genetic disorders. So things like Fragile X syndrome commonly have a childhood apraxia of speech component with them. They can be from acquired neurological damage if it's happening in the very, very early developing child. And for many, many cases, are the causes unknown. The next apraxia that we're going to talk about is primary progressive apraxia. We're not going to talk about this very much. There is, first, I have to explain something else. There is a disorder called progressive aphasia. It is a loss of speech or language ability as the result of damage to that left hemisphere of the brain. Progressive aphasia. Okay, we'll talk about aphasia a whole lot more in our chapter on adults. But the reason we're bringing it up here is because primary progressive apraxia of speech used to be thought to just be part of a progressive aphasia. It was never looked at as a separate disorder process. But science, not me personally, I'm not doing this research, science is finding that it is a standalone disorder, that it is not always tied to an aphasia. It does occur on its own. It's a very specific and unfortunately progressive neurological process, neurological disease process, primary progressive apraxia of speech. And so we're not going to go any more detail into it than that. It is just one of the apraxias. Moving on from apraxias to dysarthrias. Apraxia, remember, was a disorder of planning and programming. Dysarthria is not a disorder of planning and programming. Now the disorder is at the level of execution. It is a disorder of neuromuscular control. So there are disturbances to muscle tone, to reflexes, to movement speed of the muscles, to their range of movement and accuracy and steadiness. I want to make sure we're clear on this, though. It is not a structure disorder in the same way as, say, cleft palate is. When we're talking about cleft palate, we're talking about lack of structure, right? There's in the actual body structure, there is something absent or a damage, right? That's not what we're talking about here. We're talking about muscle movement. So the structure is all there, but the ability to move the muscles in the way that they need to move for accurate speech is impacted at the level of muscle execution. Again, not the plan or programming, the level of execution. So we're looking at a number of different variations within muscle movement. So I'm going to go through these kind of quickly. Hang on with me. Muscle tone is the resistance to passive movement. So you think about the kind of muscle activity you need for postural support. And I don't mean just being able to sit upright, but keeping the muscle tone, like keeping your lips closed. That's postural support. If you can't do that, right, then we see maybe a almost constant open mouth posture because you can't keep the jaws closed. That's tone. Muscle strength, the ability of the muscle to contract to the level desired or required. So if that's reduced, we say we have flaccid muscle movement, and we would also say we might have a flaccid dysarthria. Muscle strength, this flaccid muscle tone, can affect all of the speech production systems. So it can affect respiratory, phonatory, resonatory, and articulatory, and it all depends on the site of lesion. Remember, the place within the nervous system where the damage is. Um, and then movement steadiness. So we talked about tone and strength, and now how steady is that movement? So the ability of the muscles to generate steady movement. If it's disrupted, we're going to see things like involuntary tremors. Movement speed. How rapid can the articulators move toward their targets that are required for speech? If it's reduced, it can be what we call a spastic dysarthria. If it's increased, it can be a hypokinetic dysarthria. I am not going to ask you to memorize all the different types of dysarthria. I want you to know what dysarthria is, that it is that disruption at the level of execution. The one dysarthria that we're going to talk about, or the two that we'll talk about most commonly, are the flaccid and spastic dysarthrias, and we'll get there in a moment. Excuse me. So that was movement speed, how fast the articulatory movements can happen. Movement range, how far a structure can move. So range of motion, right? Can we open the mouth wide enough for the big, broad vowel sounds? Can the tongue move up to the alveolar ridge if the jaws are open? Can the lips retract far enough and in a symmetrical movement to produce the E sound? So range of movement of the muscles can be greatly reduced in many of the dysarthrias. And then movement coordination, the precise timing of muscle contractions so that each articulator moves in the intended distance and direction at the right time. Excuse me. So we're going to talk about types of acquired dysarthrias. And these are the classifications we use mostly for adults. We would use them for children who acquire dysarthria after some neurological incident in childhood. Children who have that neurological incident at the time of birth and it's a cerebral palsy issue, these classifications are not neat and tidy for them. So we don't use the same set of classifications when we're talking about cerebral palsy. These are acquired dysarthrias, not cerebral palsy. Please don't misunderstand. An adult can also have cerebral palsy, but they got it at the time of birth, and then it moved with them into adulthood. Okay, so the acquired dysarthrias. A spastic dysarthria, and I'm gonna abbreviate this from your textbook, and I don't expect you to remember all of these. I also don't expect you to remember all of these characteristics. So I'm gonna just again give you a bird's eye view of these. The ones I'm most concerned about. One, you know what a dysarthria is, and you understand, for example, the difference between flaccid and spastic dysarthria. So a spastic dysarthria, we have increased muscle tone, but we have weakness and reduced range and speed of movement. The hyper reflexes, so things look tightened, hyper reflexes, they move, but the tone of the muscles is very low. This is usually from bilateral lesions. Their speech is going to be very reduced in rate. Distorted consonant and vowel sounds, just huge variabilities in loudness and in stress. It's going to be hypernasal because that velopharyngeal port is just not effectively closing off the oral nasal cavity. Okay, spastic dysarthria. A flaccid dysarthria. We have great muscle weakness, even atrophy or hypotone, very little muscle tone, restricted range of movement, restricted speed of movement. The deficits in flaccid dysarthrias are going to depend very much on the cranial nerves that are affected. They are going to have very reduced breath support. So, because of that, their voice is going to be very breathy, and they're not going to be able to have, like, they're not going to be able to say a long sentence. They're only going to get a couple words out at a time because the breath support is so reduced. They're going to be very mono pitch, mono loudness. Again, hyper nasal, too much nasality. I'm not going to go through the rest of the dysarthrias. There's the hypokinetic, hyperkinetic, and the ataxic and unilateral upper motor neuron dysarthrias. I'm not going to go through all of those. Please read through them in your textbook so you see that there are just these very different characteristics for the acquired dysarthrias. When you are in graduate school, you will have to learn a lot this in a lot greater detail. For our purposes, knowing the difference between an apraxia and a dysarthria is the basic issue. Understanding terms like flaccid, what that means, and understanding the difference between acquired and developmental. We're going to move on in our next video to the developmental dysarthrias. These are the ones that come along with cerebral palsy. Everything else in the dysarthrias we've talked about this far has been an acquired dysarthria. And remember, we call cerebral palsy developmental because it happens at the time of birth. So we'll get to that in our next section. I haven't decided yet if it's a video or a Zoom. I'll decide that when you see the last slide.